All right, so we're diving deep today into foot ulcers. These can turn really nasty, and we got to know how to tackle them, especially for those gearing up for surgical boards. So we're going to break down the classifications, the causes, how we check them out, and of course the treatment for the whole spectrum of foot ulcers. But diabetic foot ulcers, those are going to take center stage today, given just how often we see them.
Yeah, absolutely. Diabetic foot ulcers, they're definitely the main event, but we can't forget about the other players in the game. Arterial ulcers, venous ulcers, got to think about malignant ones, and of course, infectious ulcers too. And we'll touch on that difference between the superficial guys and the ones that burrow deep.
So let's jump right into the diabetic foot ulcer arena. They are hands down the most common cause of foot ulcers and the complications that come with them. Every year, a good chunk of folks with diabetes will deal with a foot ulcer, and it's often a one-way ticket to infection and even amputation.
No doubt about it. And if you look at the lifetime risk, a significant portion of people with diabetes will face a foot ulcer at some point. The scary part is a lot of these ulcers get infected, and then a good number of those infections lead to amputation. Actually, most amputations from lower extremity wounds start with an ulcer.
Now, thinking about osteomyelitis in these patients, bone infection without an open wound, it's pretty rare.
Right. It's not common.
And those infections that spread through the blood even less so. So almost every case of osteomyelitis in a diabetic foot starts with an ulcer that's there.
Yeah.
That being said, a lot of non-traumatic amputations happen in people with diabetes.
So that brings us to the why. Why are these ulcers happening? The classic trio is nerve damage, foot deformities, and any little trauma.
Nerve damage or neuropathy, that's got to be a big one, right?
Huge. Yeah.
I mean, it's basically the top risk factor for diabetic foot ulcers and amputations. They lose feeling, can't sense pain pressure, even their balance goes off.
It's like they lose their protective shield.
And here's a key takeaway. The only proven way to help protect those nerves is keeping blood sugar in check.
Right on.
So we're talking about tight control there.
Tight control, absolutely.
Okay, so
Yeah.
foot deformities, what's the deal with those?
So basically, the small muscles in the foot, they start to weaken. The bigger muscles take over, and then bam, you've got things like claw toes and joints that are all out of whack. And we can't forget about autonomic neuropathy either. It dries out the skin, no sweat, no oil, just cracks waiting to happen. And the blood flow, it gets all messed up too. Now, one thing to remember, surgery on those sympathetic nerves doesn't usually do much good.
Because of the neuropathy.
Exactly. It's already a messed up system.
Gotcha. Okay, let's talk Charcot's arthropathy. We see abnormal sensations decreased or sometimes zero feeling of vibration and touch. Then there are motor problems, like reflexes that just aren't there. But here's the kicker. The blood flow to the foot is usually pretty good.
Right. So with Charcot's, you get a fracture or dislocation, mostly in the midfoot, and boom, you're left with a deformed foot. And get this, sometimes the imaging looks a lot like bone infection, so we got to be careful because patients might get treated for osteomyelitis even without a wound. But if you do see an ulcer and the bone scan or MRI is lighting up, then osteomyelitis is likely the culprit.
So we've talked nerve damage. What about the deformities themselves? How do they contribute?
Well, think about it. Those tissues stiffen up, movement gets limited, and you lose that nice padding on the soles of the feet. You know, that cushion that we all take for granted. So every step, every bit of pressure, it's all amplified and unevenly distributed.
So basically setting the stage for ulcers to form.
Exactly. And certain deformities like a stiff ankle bunions, hammer toes, and claw toes, those are often partners in crime with plantar ulcers.
Now, trauma seems pretty straightforward, but how does it really factor in?
Well, all those deformities we talked about, they're like open invitations for injury. The skin is more exposed, more vulnerable, especially to repeated trauma. Shoes that don't fit right, and any punctures, those are big problems. And often those injuries fly under the radar because of the numbness and sometimes even poor eyesight.
Yeah, it makes sense. You don't see it, it gets ignored.
Exactly. And there's this thing called the edge effect. You see, the most damage often happens at the edges of the ulcer, right over a bony spot. It's all that pressure and the shearing forces that really do a number on the tissue. And you know, those ulcers, they stick around because that pressure and minor trauma, it just doesn't quit.
So apart from the big three, what other things are throwing fuel on the fire? I'm thinking circulation problems being male, older age obesity, and those systemic issues like high blood pressure and high cholesterol.
You got it. So let's talk about circulation, or what we call peripheral arterial disease, PAD. It's a player in about a third of ulcer cases. It mainly gets in the way of healing rather than directly causing the ulcers, but it's definitely something to watch out for. Usually it's the larger arteries that are affected, and often the vessels above the knee and below the ankle, they're okay, which makes things like angioplasty and bypass a possibility.
Now, there's this idea out there about small vessel disease and diabetes, this diabetic microangiopathy. It's often seen as a death sentence untreatable. But is that really true?
Well, studies haven't really shown that it's a separate, untreatable entity like some people think.
So maybe there's hope there. Okay, let's map out where these ulcers tend to pop up. What are the hot spots?
Sure. So heel ulcers, those are often from pressure and poor blood flow. Great toe ulcers are often tied to arthritis or problems with the big toe joint. Then you've got toe tip ulcers. Those guys are usually from pressure caused by the clawing. Metatarsal head ulcers under the ball of the foot. Those are from all the pressure during walking. And then ill-fitting shoes, well, they can cause ulcers on the top or sides of the foot.
So basically, shoes are a big deal.
Shoes are huge, yeah. If they don't fit right, they can really cause problems.
Okay, so big picture neuropathic ulcers, where do they usually show up?
Those tend to be in high pressure zones on the sole of the foot. And ulcers from bad circulation, well, those like to hang out in the furthest parts of the foot, the toes or the outer edge. But the most common spot got to be under that big toe.
Makes sense. Okay, let's switch gears to evaluation. How do we approach a patient with a foot ulcer?
History is key. We need the whole story, how the injury happened, how long the ulcer has been there, any past ulcers, and how they were treated, previous infections, amputations, symptoms of bad circulation, smoking history, the whole 9 yards. We need all those risk factors we talked about.
So it's a deep dive into their history.
Yeah.
And what about the physical exam?
We got to be thorough. Check both feet, top to bottom, look for calluses, corns, any breaks in the skin, nail problems, the whole shebang. Then we document everything. The location of the ulcer size depth, what kind of tissue is in the wound, bad, good, or bad, any exposed structures, the surrounding skin, how much drainage there is, and any foot deformities.
Right, so we're painting a detailed picture there. And infection, that's a red flag, right?
Big time. We're looking for redness, warmth, tenderness, and pus. If we feel crepitus, that air under the skin, that's a sign of a serious infection with gas-producing bacteria, needs urgent attention. And of course, we can't forget the neuroexam checks sensation and motor function and the vascular exam to feel pulses and look for signs of poor blood flow.
Okay, so let's talk classification. How do we categorize these diabetic foot ulcers?
Well, one way is the Meggett-Wagner system. It uses grades based on how deep the ulcer is and if there's any gangrene.
So pretty straightforward.
Yeah, but it's got its limitations. It doesn't consider infection until later stages, and it doesn't really account for how circulation affects things at different depths.
I see, so it's not perfect. What about the University of Texas system?
That one's more detailed. It looks at depth infection and whether there's poor blood flow.
So a more holistic view.
Exactly. And these factors are really important for predicting how well the ulcer will heal and the risk of amputation.
Then there's the PETA system.
Right. That stands for Perfusion, Extent, Depth Infection, and Sensation. It was developed by an international working group.
So it's got a broader perspective.
For sure.
Right.
And when it comes to classifying infection, the physical exam, that's your best friend. Blood tests, they might not always show infection, but if it's chronic, you might see elevated inflammatory markers.
Okay, and what about imaging?
Remember those X-ray findings? They can lag behind what you see clinically. But when we do image, we're looking for signs of bone infection gas or any foreign bodies in there. And if you're taking cultures, always get them from a clean part of the wound bed if there's an infection.
Makes sense. Now, if you suspect osteomyelitis, what are the key signs?
If you can feel bone with a probe, that's a strong indicator. An MRI, that's the best imaging study. But the gold standard is a bone biopsy.
Got it. Okay, last but not least, how do we check for nerve damage?
We start by asking about symptoms, any tingling, numbness, or weird sensations. The Semmes-Weinstein monofilament test, that's a common way to check protective sensation. And we also test vibration perception.
Okay, on to treatment now. This is where the rubber meets the road. What's the game plan for managing diabetic foot ulcers?
It takes a village. You need a team, podiatry, wound care surgery, endocrinology, everyone working together.
So a multidisciplinary approach.
Absolutely. And the ADA guidelines, they highlight some key principles.
Okay, what are the big ones?
Number 1, take the pressure off the ulcer. That's crucial for healing. Then you got to remove any dead tissue, keep the wound moist, treat any infection, address poor circulation, especially below the knee, and ultimately try to prevent that amputation.
Okay, so those are the pillars. What else do we need to consider?
We're going to optimize the patient's overall health. That's key. Foot soaks, they're generally a no-no. They can actually damage the skin more. Topical antibiotics only if there's an infection, and the evidence for silver dressings in infected wounds, it's not that strong.
So we're sticking to the basics. Okay,
Yeah.
you mentioned offloading. Tell me more about that.
Sure. So for neuropathic ulcers, taking the pressure off the wound, that's paramount. The goal is to distribute the weight away from the ulcer, but still let the patient walk around.
So we're not putting them on bed rest.
Not necessarily. Total contact casts, they're the gold standard. They spread the pressure evenly and have really good healing rates, especially in wounds that aren't infected or ischemic.
But they're not for everyone, right?
Right. They require a skilled hand to apply them correctly, and they're not a good fit for all patients. If done wrong, they can even cause new ulcers.
Ouch. Okay, so what are the other options?
Well, there's bed rest wheelchairs, crutches, specialized padding, and therapeutic footwear.
Got it.
Yeah.
Now, what about debridement?
So that's removing dead tissue. There are a few ways to do it: mechanical, enzymatic, and surgical.
And surgical is usually the most effective.
It often is, yeah. Now, with dry gangrene, you got to make sure the blood flow is good before you go all in with debridement. But if the tissue is infected, you need to get rid of it ASAP.
Makes sense. And if those ulcers keep coming back even with good conservative care, what then?
Then we might consider corrective surgery for those foot deformities. Things like lengthening the Achilles tendon for a stiff ankle, releasing tendons for claw toes, or even removing bone for prominent metatarsal heads, all to redistribute the pressure.
So it's about addressing the underlying problem.
Okay.
When the wound is ready to close, what are our options?
Skin grafts are a good option for larger, healthy wounds, especially in areas that don't bear weight. And for deeper wounds or ones with exposed structures, we might use tissue flaps, taking muscle or skin and fat from nearby.
Okay. Now, there are a lot of adjunctive therapies out there. Hyperbaric oxygen, negative pressure, wound therapy, growth factors, you name it. What's the deal with those?
Well, the evidence for using them routinely, it's not always strong. Bioengineered skin substitutes, those can be helpful for some types of wounds.
So they have their place.
They do, and remember, skin grafts, they tend to do well in areas that don't bear weight, while bioengineered tissues might be better suited for weight-bearing areas.
Interesting. Now, here's the bad news. Foot ulcers, they like to come back.
They do.
And if you've had one before, the risk goes way up. So
Mhm.
prevention, that's got to be our priority, right?
Absolutely. Regular foot care, good footwear strategies to reduce pressure, patient education, it all matters. And monitoring skin temperature can help us catch those early signs of inflammation.
So it's a long game.
It is.
Now, before we wrap up, can we touch on arterial ulcers and how to manage them?
Sure. So if a patient has symptoms of poor circulation, think arterial ulcer. The exam will back that up, showing signs of reduced blood flow. Vascular studies are key for diagnosis. And treatment, we got to address those risk factors: medications, local wound care, and potentially procedures to improve blood flow.
And venous ulcers.
Those often happen when there's leg swelling and varicose veins. They usually hang out on the lower leg near the ankle. We got to check the whole venous system, and treatment focuses on compression, leg elevation, and local wound care.
Got it. Now, what about those ulcers that just won't heal? I'm thinking malignancy.
Yeah, if an ulcer isn't healing like it should, think malignancy, you need a biopsy to be sure. There's a specific type called Marjolin's ulcer that can pop up in areas with chronic scarring.
Interesting. And what about those less common infectious ulcers?
Think about travel history, or if the patient's immune system is compromised, you might need specific tests to figure out the cause, and then treatment targets that underlying infection.
Okay, let's recap some key points for our listeners.
Foot ulcers, they often come before amputations, and nerve damage is a major risk factor for those diabetic foot ulcers. Good blood sugar control, that's your best friend for protecting those nerves. If you see bleeding under a callus, that's a warning sign. And sometimes nerve damage can hide core circulation, so you got to be thorough.
Yeah, those are important points.
They are. And remember, offloading pressure and removing dead tissue, those are crucial for treating neuropathic ulcers. Total contact casts, they're a great way to reduce pressure, and monitoring skin temperature can help us prevent ulcers in the first place.
So, folks, this has been a deep dive into foot ulcers, especially those pesky diabetic ones. This info is crucial for your surgical boards, but remember, this is a complex area. Keep studying the ins and outs of diagnosis and management.
It's all about preventing those serious outcomes for our patients. Knowing this stuff inside and out, that's not just about passing exams, it's about providing the best possible care.
Thanks for tuning in.
Until next time.